All right, everybody. We are starting out 2025 with none other than a very crucial conversation to get the ball rolling for PFD and ARFID. And also, I have to acknowledge this is the first podcast that we've recorded since Dog Crossed the Rainbow. So you won't hear her offering her 2 cents in the background for the first time, which is kind of weird. So if it's actually quiet and focused this iteration, well, we're going to count that as a blessing and move on forward. To get us ready for the Feeding Matters conference in February, we have none other than the CEO of Feeding Matters, Miss Jaclyn Pederson, on the show with us today. And she brought in a lovely colleague of hers that's the head of the research pillar, if my understanding is correct, for Feeding Matters, Dr. William Sharp. And we are going to clarify and help grow the understanding of PFD and ARFID today. So folks, thank you so very much for coming on and kicking us off for the year. So yay.
Hi, excited to be here and kind of kicking it off for the year. It's a great thing to start out on, I think, as it's been top of mind for everybody is kind of what is PFD, what is ARFID, what's the overlap, all of those unanswered questions.
Yes. And I can tell you wearing two hats, one as the clinician and two as the professor. It's very interesting because I want to make sure that I'm teaching our students that will be clinicians and colleagues the correct, most current information. And so that's heavy in my heart on both hats. So now, Jaclyn, you've been on before, but it would be lovely if you could do a little recap as to how you found yourself in this world before we transition to Dr. Sharp.
Sure. Well, thank you again for having me. Always love coming on. My background is in nonprofit management and healthcare innovation and systems practice. So I like looking at kind of like the broad scope of things and taking risks and seeing what happens. And that's initially what attracted me to Feeding Matters. I came to Feeding Matters over 11 years ago as we had just changed our name from Popsicle Center to Feeding Matters. I came here before I was married or had kids or any of that. It was just, I was working at another nonprofit and this was a really interesting one. So I started as our volunteer coordinator. So I was doing some grant writing and then running our parent-to-parent coaching program. And over the years, I just fell more and more in love with our mission and kept growing our programs. And luckily enough, got to grow with the organization. And then I did get married. I did have children and all those things. It taught me a lot about how we as parents consume information about pediatric feeding. My first son, Charlie, was 7 months old when I was in the middle of thinking about all of that, of how we talk to parents about even introduction of foods and how it's hard to tell what disordered feeding is if we don't even really know what to expect from our feeding milestones. That was the summer of 2020 when I then took over as the CEO of Feeding Matters. So the former CEO, Chris Lynn, had to resign due to some family circumstances. The board of directors put me in as interim, and then I became the permanent CEO in September. Fast forward, like a lot of challenging and interesting months and years throughout the pandemic. I had George 2 years ago, and he had feeding problems right out the gate. That taught me a little bit more about the advocacy and what we need to do for early intervention. And so I feel like it was kind of a great arc in terms of how I started at Feeding Matters and where I came to from here.
Yes. Okay. And also having a baby in the pandemic and post-pandemic, that's
So Charlie was 7 months old and I took over as CEO of Feeding Matters. It was a very interesting time, I will say.
the boys were in a Mandarin immersion school, the number one charter school in South Carolina. And I was trying to advocate for inclusion of telehealth codes for feeding and for language therapy. When the pandemic hit, we didn't have access to any telehealth codes. So we're trying to do that while my 4-year-old and first grader were doing Mandarin immersion via Zoom, which consisted of learning new words and picking noses and watching friends do that because let's be honest, that's what Zoom is for 4-year-olds.
Yes.
But yes, so that's gratitude for you.
We all made it through.
We survived. Okay, so Dr. Sharp, how did you find your world into PFD? Also, you're in CHOA. I wish I had known about you before I moved back to Virginia. So
I'm at Children's Healthcare Atlanta here in Atlanta, Georgia. I'm a pediatric psychologist by training. And what that means, at least in my mind, it's the intersection between health and behavior, right? How health can impact behavior and behavior can impact health. I was at DuPont Children's Hospital in Wilmington, Delaware for my fellowship when the now director of the Children's Hospital of Philadelphia feeding program, Colleen Lukens, she came to me and I wasn't a very happy trainee. I was basically going to specialize in neuropsych, which is, in hindsight, it's really boring. You test people all day long and you give them feedback and you say, here's how sorry to neuropsych people. God bless you for doing that work. But it just wasn't my cup of tea. It wasn't life-changing. It didn't really have big impact. It was like routine. You go in, you ask some questions, you write a report. Colleen came to me and said, you might like feeding because you can have a really big impact in a short period of time. And so she introduced me to the idea of feeding as a problem, something that needed help with. DuPont didn't have a very robust program, but at least it gave me a flavor. And then about 17 years ago, I interviewed for jobs around the country and landed at the Marcus, what was known at the time as the Marcus Institute, which was owned by Kennedy Krieger back then in Baltimore, weird as that is. But I landed in their feeding program as a faculty. I had no idea what I was doing. Had very little knowledge. And I basically self-taught myself through research, through literature, through learning from the patients and families, through collaborating with different colleagues. I mean, there was somebody here when I landed here who had some experience, but there wasn't a rule book on how to do this or a guidebook. So my first research paper was a summary of everything that had ever been published in the behavioral feeding world from a psychology standpoint. And that's how I taught myself kind of what was the state of the art at the time.
yes. Well, I came from a little slice of heaven for PFD in Columbia, South Carolina, because I forged it, we'd craft it, we built it from the ground up, and we had a great network. And then the good Lord brought us back to Virginia, which has been wonderful. It's a little rural to start with. There's beautiful things like Santa Claus coming through the subdivision on the back of a fire truck. But then there's which was awesome. The candy was really good. But then there's disheartening things as in access to care and simply understanding that this diagnosis exists, and then add in what is ARFID on top. Almost 20 months of just scratching the surface to get pediatricians in the area on board in the Shenandoah Valley. Because if you look at the map, it's very rural all up and down the valley. We live in the most populated area, which isn't saying much. And we have colleagues, and by colleagues, I mean psychologists, speech pathologists, occupational therapists, and caregivers up and down that get mixed messages from their primary care providers because we just need to do more. But how would you describe the overarching differences? Could y'all just kind of help outline the differences between PFD and ARFID from the grounds of somebody who is just starting out? And then you mentioned there was something newly printed. Are we allowed to talk about that?
Yeah, we are. Let's talk about that.
Okay.
So, well, I'll let you take that first and then I can add on top of it maybe.
Yeah, I will be, and Jaclyn knows this, she probably heard me say it before. I didn't understand the reason behind PFD, to be quite frank, I was an ARFID proponent. Let me tell you why. So as a psychologist, I have to rely on the DSM, which is the Diagnostic Manual for Psychologists and Psychiatrists, Mental Health Professionals, right? And in DSM-4, there was a diagnosis called feeding disorder of infancy and early childhood.
Yes.
And it wasn't a very good diagnosis, no offense to DSM-4. The reason it wasn't very good was because you had to be underweight or losing weight in order to meet the diagnosis. So you could have a feeding tube and eat nothing by mouth, and you'd be like, doesn't meet criteria because you're not underweight. So we were really handcuffed in some ways with who we could see related to the diagnosis. So when ARFID came out, it was a beautiful thing because it had G-tube. You could be dependent on a G-tube or formula. You could be underweight. You could have nutritional deficiencies because we were seeing a lot of kids with autism and really narrow diets who were getting things like scurvy and rickets, and they ate food and they weren't underweight. And then there's the psychosocial impairment. So to answer your initial question, when PFD came out, PFD was, so ARFID's a psychiatric diagnosis to really account for avoiding and restricting food in general. That's related to 3 reasons: sensory-based characteristics of the food. You don't like the food for some reason, fear of food, or just ambivalence to food. And those are the three drivers they're thinking that in the ARFID world. PFD is a broader diagnostic multidisciplinary umbrella that captures feeding disruption that could occur across 4 domains: a medical domain, a nutrition domain, a feeding skill domain, and a psychosocial domain. The 2 diagnoses overlap significantly in terms of the nutritional outcomes. That is, they almost verbatim have the same nutritional outcomes, feeding tube, nutritional formula supplementation, weight loss, and nutritional deficiencies. And they overlap with psychosocial. But what PFD really does a nice job of capturing are kids with medical or feeding skill dysfunction that's leading them to not be able to eat because of a underlying medical issue or underlying feeding skill issue. The DSM-5 does not even speak to medical. It speaks to medical by saying you can't have a medical condition that's causing ARFID, and it doesn't speak to feeding skill at all. So I'll stop there, and Jaclyn, you fill in the gaps with that.
Yeah, so ARFID came out in 2013, and PFD, we published the paper in 2019 and then advocated to the CDC to get the codes in 21. And so that's a huge difference of time in terms of how long ARFID was out there versus PFD. And so what we were hoping to do with PFD was build on discipline-specific diagnoses like ARFID and be able to think about them more holistically. So even outside of the diagnosis of PFD, the PFD framework, and how does that impact function and daily life and all of those different things. So that was the intent behind PFD. And then it comes out and we get further down the road and we realize not only is it confusing for healthcare professionals and parents to see the diagnosis of ARFID and the diagnosis of PFD, but it was also confusing because ARFID was out there sooner, so it got more popularity. But ARFID was picked up by the eating disorder world. And so it had a lot more research, and the research pipeline and the research capacity and the sophistication of research in the eating disorder world is significantly larger than the pediatric feeding world. It was this power imbalance that you saw ARFID just shoot up and take off very rapidly. So it took off rapidly in the research world. And then that had its tentacles and like the domino effect in the general public world. So now we're starting to see on social media how rapidly ARFID is being taken up. And so that was one of the things that Feeding Matters, we were like, okay, it's confusing for the healthcare population, confusing for the patients themselves. And we were hearing many stories anecdotally of families receiving an ARFID diagnosis for like a 2-year-old at a primary care pediatrician office because they didn't know how to describe weird eating, quote unquote, weird eating. But they had heard of this term ARFID. Maybe it was even to the general public and not even through any sort of like medical community and academic like informational pipeline, but just the general public. And so we were seeing ARFID be assigned in a lot of places, even when, and with no questions about how is swallowing looking, what are the feeding skills, what is age appropriate eating, where are we at with all of the different domains. And so it was really concerning in that sense. And that was at the time that we met Will, actually, in terms of him saying, oh, I really love ARFID. We were like, what? And so we started meeting with him a lot. And it was a really great conversation to start with, at least with just the general research initiatives task force of like, okay, like let's unravel this. And so then we started with an infographic that we came out with from Feeding Matters umbrella that says like, let's at least look at the 2 diagnostic criteria. But then we still saw the need even further. And like Will was saying earlier, we really saw the need to merge these fields together and have the eating disorder field talk to the pediatric feeding field and have vice versa, because there's so much that we can learn from one another. And so I know you asked your initial question of like, what's the difference between the two? And the reason the answer is really long is because I think it's a continuous discussion.
Yes.
So the real answer is a child can be diagnosed with both. If a child is young, super young, up through middle childhood, pediatric feeding disorder needs to be considered because a child is in the feeding developmental window. We didn't realize how long children are developing their feeding skills and refining their feeding skills. That was a big aha. That's kind of the answer to your question. We brought together the eating disorder field experts and the pediatric feeding disorder experts in a consensus meeting in 2023 and developed 10 consensus statements to really help people think through what diagnosis they assign or what is co-qualifying diagnoses. And that's the paper that was published in middle of December 24. And I know we're now in January 25, but we're recording this on the day that it was actually published. So that's pretty exciting too.
That's amazing. Yes. Okay. So on our side, I can tell you, I've been practicing for just shy of 20 years. Never had any academic training on PFD. I had, I think, one night in one class on peds dysphagia. Started working clinically, and everybody came to me with a failure to thrive diagnosis was the buzzword. Was around and practicing in 2014, 2015, 13, 14, 15, when ARFID hit the wavelength, just like you said. However, there was confusion on who could give the diagnosis. So I worked with speech pathologists who were giving an ARFID diagnosis, which, folks, if you are listening, that is outside of our scope of practice as a licensed speech language pathologist.
The mental health diagnosis.
Yes, we cannot, under any circumstances, give a diagnosis of ARFID. We can, however, say, little one is presenting with signs and symptoms of, please consider a referral to. That is how we engage in interprofessional practice while respecting boundaries, but also in order to efficiently engage in interprofessional practice, you have to be steeped in interprofessional education and know what this diagnosis means. Dr. Sharp, I saw you pop up like a jack in the box.
But let me add something else that's really weird about ARFID. ARFID, in order for it to be diagnosed, you have to have a dietitian help you out. Because as a psychologist, I'm not trained in looking at, I mean, I can figure out a growth chart, but like, I'm not trained on growth charts. I don't do nutritional analyses. I don't look at formula supplementation and things like that. So it's ironic that you're correct. It is a mental health diagnosis that requires input from a multidisciplinary team to really render a good diagnosis.
Yes, but also to get back to those growth charts, those things are the bane of my existence because those growth charts are predominantly predicated on upper middle class white families from the Northeast. And that's not consistent of my caseload. And then there's separate growth charts for certain conditions, such as children that have Down syndrome. So do the current, whoever is taking the measurements, are they actually plotting them on a correct chart? And is that disorder, genetic condition, consideration specific? And that is not always correct. So just as a folks, if you're not familiar with that, I know for National Down Syndrome Society, they have tools for their own developmental growth charts. So please go directly to the source. HIE, Hope for HIE has some new tools out now there. So I would go to the source, y'all, go to the source. Okay. So how, I know Feeding Matters has done so much. Can you talk to a little bit about these 10 principles to help clarify?
Yeah. And I think the biggest things that came out of the consensus meeting were that A, we needed to be talking to one another. B, that the feeding developmental window is what we ended up calling it, is much longer than people realize. And that's from a lot of like recent research, actually, because even early on in Feeding Matters life, we were saying that, you know, children were kind of, their feeding skills were developed by like 3 to 5-ish. And I know we've learned recently that it's like 7, and we're even seeing some refining of skills all the way till like 13. So that was a big piece. And then the medical and feeding skill assessment piece was also a really big aha that came out of the consensus meeting, which was we can use the words, we're doing a medical assessment, or we're doing like a medical screening or anything like that. And that is used in the ARFID community, and that's used in PFD. But the reasoning and definitions and what people are doing behind those words is very different depending on your discipline and what like diagnosis you are used to working with first. And I think, Will, you were the first one to point that out, that we're speaking different words. And part of what we were trying to do with PFD was ensure that we had common language where we could talk across discipline so that we're talking about the same things. And so that's kind of what we see with this work of the consensus of PFD and ARFID. And we can dive into the 10, but Will, I didn't know if you wanted to talk to that of like, we're kind of like using different words for the same things or different things with the same words and really trying to unravel that.
Well, and I think that one of the things that when ARFID hit the diagnostic nomenclature, that these children were trying to go get services somewhere and they were landing at eating disorders programs because there are more eating disorders programs available than there are feeding disorder programs, especially multidisciplinary comprehensive ones.
Yes.
And what happens is they were getting what in the eating disorders world, one of the interesting things they were doing is they were taking established treatments for like anorexia and trying to downwardly extend those treatments to ARFID as if all eating disorders, and that was their toolbox. They had their toolbox. They said, here's our toolbox with this toolbox apply to ARFID, and it turns out probably not. But we were finding these families afterwards, and they were like, we just came from an eating disorders program where they admitted my 6-year-old, and I'm saying he because there's a lot more evenly gender distribution with ARFID than there is with anorexia. So you get about half and half males to females with ARFID, and you get about 95% of anorexia. So, they were applying it to a younger cohort, a totally different presentation. So I think starting the dialogue between the two groups was really about recognizing that these younger kids should really be served in a different setting or use a different treatment approach than an eating disorder approach.
Mm-hmm. Yeah. And, Michelle?
I'm imagining the conversation that I had with a very large, robust mountain man of a daddy a couple weeks ago, trying to explain that this is not his son just being difficult. This is truly something different. And then trying to chisel away at this ingrained bias against mental health practitioners' care in children, because it falls in the line with where we live right now, right? And I know I'm not the only individual that's encountering that. So it feels very raw and very home because, as a practitioner, I can only do so much and take them so far when I know that we need to get to specialty clinics, and there's like 2 for the entire Commonwealth of Virginia, maybe 3. Yeah.
Well, we did a paper. I don't know if you've seen it. We found 16 like in the country. So you had to be multidisciplinary. You had to offer a day program, like a Monday through Friday, 40 meals a day. You had to be at a hospital-based system or an academic situation. But those were trying to identify probably the most well-resourced programs in the country, and we found 16. Most of them are on the East Coast, and most of them are up in the Mid-Atlantic. And we are one of the few in the South, and there's really a gap in the West. But I want to speak to this idea that you're talking about helping parents and families and clinicians understand ARFID and PFD, right?
Yes.
I think we all have, in the way I usually talk about this is we all have a relationship with food, or we would not be, walking and talking, because food is vital for our growth, development, and so forth. But most of us enjoy eating. And because most of us look forward to eating and we enjoy eating, it's really hard to wrap your head around something where food has such a negative association. That's what ARFID is very distinct from other eating and feeding disorders, is ARFID by its nature is about a negative association, a negative learning history, or, so forth, where the children actually don't like food the same way that we like food. And so they actually have a different relationship, and that's critical for these parents and clinicians to understand.
Something that our profession struggles with is, how do we teach counseling skills? Counseling skills, as a speech language pathologist, it's almost intuitive. Either you have it or you don't have it.
And developing those soft skills is very challenging.
And more progressive graduate programs that have electives might have a counseling class embedded within, but very few programs even have a standalone PFD course. It's part of the dysphagia course, which is historically taught by adult dysphagia researchers, which is a totally different skill set. So I feel for our own specific profession, we're playing catch up from the moment you come close to graduating.
I mean, it's an incredible problem because it's not only you're touching on the need from the mental health aspect, especially because this is disorder that happens in childhood. And so you are working both at coaching and talking to the parent or caregiver, as well as the child and patient themselves. And one of the things that I think was my biggest aha with PFD and ARFID, or I guess not aha, but the thing that made me feel most responsible as Feeding Matters was, I think we're seeing a bunch of ARFID cases right now, not only because of the rise in popularity and the better general public understanding of it, but because of the vacuum that exists within the pediatric feeding world. And
Yes.
so if you're growing up not identified or going to unqualified therapists or not getting the care that you need right away, you're building that negative association on top of negative association and trauma on top of trauma. And that's what's giving you this really negative experience for meal times. And of course, it's going to turn into ARFID and you're going to develop ARFID
Yes.
because you're not getting the care that you need and you don't feel safe at meal times. And so for me, when we were trying to navigate, like, what is PFD? What is ARFID? What is the overlap? That for me was like the biggest thing that I felt like as Feeding Matters, we have a responsibility to make sure we're supporting PFD and supporting ARFID because they are so linked that you really
Yes.
can't look at them separately. And that's also what I would share with any like speech language pathologists too, who are worried about you're seeing just an ARFID patient. It's a PFD and ARFID patient most likely, and that's where your
Yes.
piece comes in.
Yes. So clinically, folks, when you're looking at how do I document this, I would give you recommendation. Dr. Emory Goza last year, who just got an ASHA Fellow. She was just nominated and received her ASHA Fellow this past December. She led the new updated Journal of Speech Language Hearing Science publication that came out the early part of 2024. You have access to it for free with your ASHA membership. You can go in and you can access all of the articles, but I know my template is in there and it's free to access. And there's other clinical swallow eval templates in there that break down how to document what you're seeing. Because if you don't document it clearly on the eval in layman's terms, then the caregivers are going to struggle to understand, as well as any other interprofessional practice partner, including the PCP, especially if they're not familiar with it. So when you're documenting it, there's ways to do it and there's examples out there. So please go to your resources that have been vetted. Don't just follow something on social media because it's been posted. So on that awkward turtle note, what lovely social media references and resources do y'all have available for helping?
Oh, it's just so funny that you say that, just because I think on the parent side, social media is both
Yes.
challenging and not and really complicated because you've got so much information coming at you from a parent on how to feed your child, what are some tips and tools. And when you have a lack of support, you turn to social media because you're getting something out of it. And that's the same that's happening in the professional side too, is we have a field that doesn't have a lot of support. And so we need to figure out how to get to what we get to. And it can just be really challenging to know, how do you pay attention to the right sources? What are vetted sources? At Feeding Matters, we feel really important to vet a lot of resources, and we spend a lot of time doing that. So it ends up taking us a while before something can get out the door because we do spend a lot of time doing that. But we are really excited to share the summary of the PFD and ARFID work and the consensus work. And we will be doing that on social media because a lot of it is really critical to supporting professionals' development, but also the patient and family experience too, especially in that critical overlap of when PFD is transitioning into ARFID and we're seeing a child grow up into an adult that has that negative experience. But from a social media perspective, we do try to vet all of that's where Feeding Matters PFD Alliance comes into play. And we really work with a lot of professionals to make sure that what we're putting out the door has been vetted.
Yes, yes. Dr. Sharp, where do you see our overlap from like the clinician who typically kind of gets it started? Because normally they end up on the SLP's doorstep first. So how do we efficiently get them from us to you and then collaborate together?
I mentioned earlier, there's not a lot of these comprehensive centers are not widely available. I think going back to your point about knowing what questions to ask and when to ask them and how to ask them is really important.
Yes.
So, I'm now in a very good place with both diagnoses. I think the consensus that we have coming out is the first step in truly having a good understanding of both and how they complement one another. So let me take, I started off by saying, Jaclyn noted, I love ARFID, but what I really mean by that is, like, I know, my team knows, we have a lot of history with treating, avoiding and rejecting foods from a behavioral standpoint through a lens of a behavioral approach. And that basically means we're viewing this as a negative association with food. From a PFD perspective, on my team, we have a GI doctor, a speech language pathologist, an occupational therapist, members of teams who are answering questions. We wouldn't start treating ARFID until we've either identified or determined that the medical conditions are actively managed or resolved. Because the first thing we're going to view is, how did this negative association form? Like, why does the child not like eating? Because remember, I said we all have a relationship with food, and for most of us, it's a positive relationship. So my first question, as a clinician, I'd want your team, the SLPs, to be asking is, what is causing this child to reject or avoid food, right? That's the first question. And then I'd want to have a medical provider do a full medical workup. And I got to say, some medical providers are not as concerned as I am when children are rejecting food. They're like, oh, they'll grow out of it, or oh, it will get better on their own, right? So we need to be emphasizing that not eating's weird, and that, we are biologically pre-programmed to like food. And so when you're not liking food, something's gone wrong. And so we need to check off that medical checkbox to say there's nothing ongoing that's causing this. Then from a feeding skill perspective, we need to make sure that the food avoidant or rejection is not because we're feeding the child an inappropriate texture, and that we are aligning the child's skill level with what we're asking them to do from a feeding perspective. And if those two things are not aligned, that's something that the SLP group should very much under their wheelhouse of aligning that. And then I think finally, making sure that you're involving the parent from the very onset. So when I first evaluate a parent, I'll be like, so what have you been doing at home? What have you been learning in therapy? And quite frankly, I hear a lot of time is, we weren't participatory. I didn't go back and watch. And so that's a big gap, right? I literally did a consult the other day of a mom who was she went through the SOS approach, and I'm not advocating for branded and unbranded. I'm not against or for anything, but my question was, whatever treatment they were doing helped get new foods on board in treatment. I said, but did they teach you how to adopt it when you got home? Were you involved in the treatment process from the very beginning? And oftentimes the answer is no. And so parent involvement is my answer. Checking off the medical boxes and answer, feeding skills, huge with PFD. And then if ARFID is involved, looking to try to build, we have a paper that's out. It's about the treatment landscape of intensive multidisciplinary programs. That can be a resource for the people to know where they can refer. Our program here in Atlanta is one of the largest at this point. We have 32 slots at a time. We take 32 patients in our intensive model. I like to think the field's moving toward what, the words trauma-informed or patient-centered or child-led, but it's moving away from viewing this as an active food refusal to really viewing it as, this is something that the child has learned and needs to unlearn and develop that really positive association with food. I went way off on a diatribe, but I hope I somewhat answered your question.
No, you did.
I think you.
Yeah, go ahead, Jaclyn.
Yeah, no, I think you did well. I think what was nice about some of the research work that we've done is, Will mentioned the paper of assessing the treatment landscape of the different programs, but we also assessed the educational background and what the specialty education looked like, especially for SLPs and OTs that are treating this. And both papers kind of came out that the community is treating a lot of these kids, but that relationship between heavily resource center that's located inside of a hospital, and then community provider who has done whatever they can to make sure that they're getting the education they can. It's a huge gap between the two, and our children and our families are kind of left in the middle trying to figure out where to go next. So I think also, as we continue with this work, really getting a better sense of how can we ensure a family and a child and a patient goes through the system in the way that makes the best sense for what their needs are. And right now I feel like it's kind of a shotgun approach based on where people can find. And that's why we're seeing insane wait lists and inappropriate care in some places. But it's just, if we can find a better way to ensure collaboration in the movement through the system and a way that makes the most sense for what the intervention is, I'd love to see that.
I have notes. This is amazing. Okay, so folks, everything that they're talking about, you can do. It's who is filling your cup so that you can effectively then turn around and fill another's, right? So a couple of recommendations. One, if you're a speech pathologist, then by all means, please join your state association. Your state association is what drives change locally. ASHA guides from afar, but they cannot, nor will they, register a lobbyist at the state level. That is your state association's roles and responsibility. The national level lobbyists can mentor and support the state association lobbyists, but it's helpful if you understand the difference right out the gate. From that starting point, get your state association involved so that the PFD screen from Feeding Matters is used within the early intervention framework. If we embed that screening tool, then right out the gate, when the child gets referred for early intervention and they have to do the 5-domain test, which is typically like the Battelle Developmental Inventory, where they look at language, fine motor, gross motor, cognition, and self-help skills, PFD often falls right within that self-help skill domain. So it just slides right in there. And then we're starting these babies out right from the gate. Now, if you get them into early intervention, or if they're in a clinic, or if you're doing home health services, how do you counsel? How do you pull the caregiver in? One of my favorite resources, and this one is branded, is the Family Guided Routines based FGRBI.com. Dr. Frances Burns has inherited from Dr. Juliana Woods, brilliant speech pathologist. It's all about how, and Frances Burns was my mentor, but it's all about how to hold meaningful conversations so that your caregivers are empowered, so that when they go in to meet with the pediatrician, they can say, my child's presenting with these signs and symptoms. How do I feel equipped to request the specialist? Because I can tell you, even if we document it, doesn't mean that the PCPs are always reading our documents, because they're drowning in their paperwork. It's not out of, how do you say that word, malevolence? Am I saying that word right? Like out of harm. They're simply overwhelmed with the amount and volume of paperwork. But if we're documenting it and the caregivers have been empowered because we've learned how to coach, then when they get into the specialist to work on getting those baseline medical conditions addressed, then they're set for a long-term healing. And Dr. Jean Marshall and Dr. Madeline Ratz out of Australia have a huge body of research to support telehealth interventions. If you want to bridge from clinic to carryover, and you can't physically go to that tiny human's house or maybe that teenager's home, then that's your opportunity to pull telehealth in. And if your state doesn't pay for it, I go back to the start of this little tirade. That's where your state association advocates for getting those CPT codes reimbursed for telehealth, because it helps you kind of go full circle. Thoughts? Dr. Sharp, what are your thoughts, sir?
I love the concept of a caregiver empowerment. I think one reason that ARFID and now PFD have been so embraced, studied, researched is because they had a name for it, right? There was a name for something, and that parents could latch on to the name for it and say, this is a thing. I also think you mentioned social media, and I think oftentimes because there's such a gap in care in terms of the community capacity to serve these families, that they're going to social media because they've been going through this experience of the providers don't know what to do, the community doesn't have treatment. So most of my families that land on me, they want to tell me this long story. The story is almost always the same. They had a young child with medical or developmental complications. The child stopped eating or dropped foods or wasn't eating at all. They went to a bunch of different subspecialties. They all gave them different answers. There was no comprehensive approach to the care. They somehow randomly get a referral to the multidisciplinary feeding program at Children's, and they come in, and we've seen tons of these cases, but their unique experience, because it's been their experience in the healthcare system being bounced around, that it's not until they land at a place that knows their story that they feel like they've finally been heard, right? And so I think to your point about caregiver empowerment is like allowing the caregiver to tell their story and also navigate their care so they can get where they need to be to get the right treatment.
Yes.
Yeah.
And Feeding Matters has the scholarship. How many people your way for that to help get them there?
Yeah, because it's hard sometimes. A lot of the times you are having to agree to something that you don't know that your insurance will reimburse or is above and beyond what you're able to do. And so we wish we could do more of that, and we have hopes to grow that. But we do have our family assistance program that allows for us to be able to grant some funds out to families to use in whatever way that makes sense for their child's PFD or ARFID. And then, Will, while you were talking, it reminded me of something that I'm actually really excited that we're able to do next year, is we're going to be telling 2 families' stories of from the very beginning, what that looked like, and kind of whether it becomes like visual form or more of a written form, but the same story that looks very different based on an individual's experience, but the one that we've all heard, which is, I started saying something was wrong at 2 weeks or even before that at my next day appointment. And then I waited until the 2-month appointment. And then we waited on a wait list for 6 months before we saw GI. And then we tried 5 different formulas before we got this. And really being able to detail out all of those different like intervention points almost of just time lost. And so I'm really excited to tell 2 patient journeys next year when we get that work done.
Yes. Clinically, as a speech pathologist, I remember graduating and thinking I had to fix it because all of our case studies, every case study it was in school, it was essentially put on you that it was your responsibility to identify the etiology and work for the intervention. And then you get out there and, now we have a definition for PFD, but back then it was just picky eating or it was oral dysphagia. And when I finally let go of it being me and recognizing the power of the team and how you can be the best feeding therapist in the world. Folks, you can do the most amazing modified or true SOS approach or food chaining or get permission because there's all of these brands and they're lovely and wonderful. But if that child is not healthy, we're not going to go anywhere. If that child and that caregiver don't feel safe, you're not going to get anywhere. I've had kids that have had to, in the last 6 months alone, I've had a 2.5-year-old diagnosed with a super megacolon. And that's why we had emesis because nothing was going out. So it was coming back up. But the pediatrician refused to listen to the mother. The father had to go in and the father had to say, you will give my child a referral to GI because sexism in medicine. I had one child come to me and the caregiver was adamant that they were too pale, check their iron, and they ended up having to have iron transfusions. Iron was in the toilet. Once we got their iron elevated, then they wanted to eat. But I mean, outliers, but are they? Because so many kids come with this. It's just that we have to dig deeper for it.
So I have a thought related to this, just as you were talking. So not eating is weird, right? Like, and so like when you're, but it's also not weird. And let me explain that. So what is a psychologist doing treating feeding problems? Well, we are also biologically pre-programmed to avoid things that cause harm or make us sick.
Yes.
So if you think about something like a stomach bug, you mentioned your children, I'm sorry to bring them up, but
That's so frantic.
one of the most common exercises that I do with families when I'm first working with them is that, can you tell me a time when you've thrown up? So get that in your brain. You've thrown up because you got sick the night before from eating something, right? You ate something and it made you sick. And how often have you gone back to that restaurant and ate again? Most of the time they say, I've never touched it again, or it was like, I've never eaten that again. The reason you don't eat it again is because it takes a learning experience of one to avoid something that causes you to get sick.
Yes.
And so imagine if every time you ate, something is painful, uncomfortable, or fatiguing. And
Yes.
that is these younger children with PFD that go on to develop ARFID because they're associating food with something really negative. And so I think the other piece of advice I'd give, when should you involve a psychologist? But ARFID is really the embodiment of avoiding and restricting food intake because of that negative association. That's a learning process. If you're young and you miss out on developmental windows of learning to eat, you're also going to grow up and have an inherent feeding skill dysfunction as it related to becoming older and not being a well-versed eater. So involve a psychologist when it's relevant and make sure that you're looking at it from this learning perspective and checking off whether or not there's still something ongoing that be causing that pain or discomfort is truly important before, I don't reintroduce food until I've checked all my boxes ahead of time.
Yes. And that's so hard clinically to get folks on board with sometimes. I have a little guy on my caseload that I literally said, this is not the time for feeding therapy. He is not sleeping through the night. We went on for 6 weeks of trying to do therapy and Bubby kept coming to clinic asleep because he was so exhausted by the one opening in my schedule. And I had to discharge because ethically I can't bill for this. Like we're going nowhere. The medical team all sent separate messages that they were really upset that I had discharged. And I said, okay, but he has to be awake and he has to be healthy. And until that's resolved, I can't do anything. You can't do feeding therapy if everybody is asleep or caregivers are so upset that everybody's asleep that we're tearful. Gut wrenching as the therapist to be like, this is not the time, but I'll be here when it is.
Well, and like I think as feeding therapists, everybody's been so used to like kind of drinking out of a fire hose of like so many of these kids and trying to get to them that there are times when we've got to slow down and say, when is not the time to do this? Because we need to be figuring out where the pain is from or what else is going on, or getting some other like environmental and family things in place before we go down that road too.
Yes.
There's a readiness.
Yes, there is. Also, when you're working with medically complex children, there's a natural, especially for our neuro patients, there's natural rises and falls when you're going to have seizure breakthrough, and it tends to correspond to like weight gain, or if there's a bleed extension, or just if you have a child that has a known degenerative condition. So it's okay to say we need a plateau here. Also, for some of our friends, the feeding tube is not the enemy. Your feeding tube is there so that you can have quality, not quantity. And that is so misunderrepresented. Yes, I teach people to swallow, not to talk. Lord Almighty.
Jaclyn knows this about my feeding tubes are a medical intervention. They're meant to make sure you have a means to get your nutritional needs if you're not eating orally. What's interesting about prioritization, so years ago, this is an anecdote from my own work, is we opened a tube clinic, and we basically had all these families with feeding tubes, and we had a psychologist go in the room and be like, and we can help wean from the tube. And about 2/3 of the parents were like, we don't want you to wean from the tube. Like we and I think there's a balance between what you're prioritizing and when you're prioritizing and why you're prioritizing it. I recently saw a 15-year-old with complex cardiac issues and developmental concerns, 100% on a feeding tube, maybe more like 60 to 70. But, we were saying we can wean on purees and liquids if we wanted to. And the mom's like, that's not meaningful for me. I'd rather keep the feeding tube and you teach them how to chew and actually eat like regular food that a 15-year-old should eat. So, it's really about the priorities of the family, what's realistic for the family, what's really meaningful for the child and the family. So I think sometimes you can get lost in what you think is a goal for the family when it really should be driven by their wants and needs.
Yes. And how well have they been informed about long-term prognosis, especially for those complex kids?
I think, yeah, what are we expecting to get to? I think is a conversation that we all aren't used to having. And that's even been our learning too, as like, how do we talk about feeding tubes at Feeding Matters as a life-saving tool?
Yes,
It
yes.
takes the pressure off of families.
Yes, it does. Okay, so Feeding Matters has the Power of Two program, which is where one caregiver mentors another caregiver. And that program, when I'm charting in my eval, and again, it's out there, feel free to use it, customize it, build it, tear it apart, make it better. When I chart the psychosocial piece, I always indicate whether or not the family would benefit from skills from the Power of Two program. And I always educate my caregivers how to find it. We had Athena came on a couple months ago, and she was talking about how long she stared at the Get Help Now button because she was so overwhelmed just to push the button. But I have sat with caregivers in a therapy session and said, I can only get you so far. And I'm not there after hours. I'm not there on the weekends, and we don't have resources nearby. But having another PFD ally and warrior, not like, oh, I'm so worried, but like Xena warrior princess, like that is the purpose of the Power of Two program. And I had two mommies in South Carolina mentor each other. One of them, you know very well. I'll never forget the other mommy was like, I wish we had done this sooner. Like the quality of life for the whole family just greatly improved once they got the feeding tube and they talked through how to do it and what to do with it. Dr. Sharp, I know you have a tight turnaround. So please give us your final, what you wish every speech pathologist knew about psych and feeding.
I think that we've come a long way in the past 15 to 20 years in terms of what we know about how to treat these issues. There's a lot of cool tools in the psychosocial domain that are useful. For instance, if you're looking at learning being the underlying way that ARFID develops, we know that psychologists are great about teaching new behaviors. I do think that there's an acknowledged bad reputation for a lot of the work that was done 10 to 15 years ago in the psychosocial domain, because I think we were trying to figure it out. I think the field's come a long way. So I guess I'd encourage everybody to almost revisit or relook at what's going on in the psychosocial domain a little bit more. A lot of it's being published in journals that may or may not be read by speech language pathologists. So that might be some of it. We've tried to do a better job of publishing in more mainstream journals that aren't these very niche behavioral journals. So, but yeah, and I think, all behavioral treatment's not the same as well. So I think, be mindful of where you're sending them and figuring out what their approach is. Even some of my colleagues who I know very well and respect, we're going to do things a little bit differently, if not a lot differently with some cases.
That gets back to the onus is on us to learn how to network, to learn how to grow outside of it's incredibly powerful to attend ASHA or your state association conference, but attending a different disciplines conference or facilitating opportunities to learn from the other discipline. That's huge. Feeding Matters has a podcast now, and there was an ARFID. It's adorable. I have totally given those resources to caregivers. I'm like, oh, there's a new episode. Also, bowel sounds. Have y'all heard of bowel sounds? Bowel sounds is by the Nasafgan.
Yeah, Nasfigans. It's Nasfigans GI one. They also have a nutrition.
Oh, wow.
Nutrition
Yes.
pearls.
Yes, but I'm just saying, bowel sounds.
Oh, I know.
GI,
I love it.
They're.
Huh?
Yeah. But can you tell us about the Feeding Matters podcast?
Yeah, so it actually came. So as Will mentioned, I think we're in this new era of figuring it out and building the research. And for us at Feeding Matters, that means really leaning into family and patient-centered research. And so we were funded by PCORI to build a family and patient-centered research consortium. And so we've been doing a lot of training of the state of PFD and ARFID research and research fundamentals. The project team, which Will is on, was we need to turn this into a podcast so more people can do it than just the 20 members that are on the consortium. And I've been saying no to a podcast for 5 years at Feeding Matters. I don't know why, but I have. I was just there's so many out there. We don't need to be one of a bunch. And so then talked into it. We were okay, we'll launch at least the trainings and see where it goes. But it's called Feeding Does Matter. And we really focus on what's family and patient-centered research and really wanting to share lived experience and talk about family and patient-centered research, because that's the niche that we feel needs a lot of attention right now.
Yes, it does. But you present it in a way that it's not intimidating.
Well, Dr. Haley Estrom's the reason we can do that.
Please extend my gratitude, because what's awesome to me is to sit there on a Tuesday afternoon and say, hey, I've sent you this link. Just if you do nothing else this week, just tune into this one thing. And I can trust the source, which is also.
Well, that's what's hard in podcast realm as well as social media realm, because we just get on here and we talk. And I've even been okay, I said that thing, and did I remember the source that came from that I said on a podcast somewhere? And so we do need to be talking in the places where people are finding this information, because we feel like Feeding Matters is a good source to go to for that information.
It truly is. Yes. Okay. Well, I want to be respectful of our time, so I will wrap us up, but ever so quickly, you have a big event coming next month over in Phoenix. So you want to hype us up about that?
Yeah, so excited to be back in person since 2019, but our International PFD Conference is February 21st and 22nd in Phoenix, Arizona, sunny Phoenix, if you're in a place where it snows. It'll be a great one. The committee has done an amazing job putting together 2 days of really great information. And our theme is Get Curious, because we are in this space of really needing to figure out, where is the field going? What do we need to be questioning for ourselves, and maybe questioning previous learnings that we've had? Multiple disciplines there at the conference. So that's your great chance to network as well, to circle it back to what we were talking about before.
Yes.
I hope to see you
there. I've already booked my hotel.
Love it.
It's Dr. Rocky Garcia and Dr. Amy Delaney are the chairs, right?
They are the chairs. Yep.
Yes. Also, y'all, Amy's got so much fun research coming out now about developmental norms, and it's just so exciting to see the progress being made. It's truly built on a council of elders and greatness. So thank you with a whole heart. Folks, every episode I always ask if anybody's got any love money, where could they donate it to? And oftentimes we say, that's my grandma's phrase, if you got any love money. But often folks reference the scholarship or Feeding Matters in general. So please consider, I know it's the start of the year, and you might have already, be replenishing your bank account, but if you got a little extra, this would be an amazing nonprofit to support because of all the great work that they're doing. Dr. Sharp, Jaclyn, thank you so much for coming on. And just give me one moment and I'll switch us over, okay? Thank you. And we're gonna stop.